Welcome, everyone. We see that people are logging in. You are joining NASHP's Hospital Cost Tool demonstration webinar. I'm just going to give it 1 minute to let people log on, and then we will kick it off. Okay, great. Thank you all for joining us. Welcome to today's webinar, where we will be demonstrating how to use NASHP's updated hospital cost tool. For just one bit of housekeeping, I want to direct folks to their Q&A icon. That's how we'll be answering people's questions. If you have questions throughout the demonstration, please do add your Q into the Q&A, and we will answer them all at the end of the webinar. I hope some of them are answered as we go through the tool, but just to make sure, please feel free to add your questions as we go. I am Maureen Hensley Quinn, Senior Director of Coverage, Cost, and Value at the National Academy for State Health Policy. This webinar is being brought to you with support from Arnold Ventures. Arnold Ventures also supports the development of this tool. Before we get into the details of the tool, we just want to remind everyone that the National Academy for State Health Policy, NASHP, is a national nonpartisan organization that is guided by an academy of state health policy leaders across 46 states. These leaders represent Medicaid, public health, departments of insurance, legislators, and more. NASHP's vision is to improve the health and well-being of all people across the states. Our priorities and approach to our work are informed by the Academy members. In our day-to-day work, we support research and analysis and facilitate state-to-state sharing and technical assistance. Healthcare affordability has been and continues to be a key state priority. NASHP staff has had the opportunity to connect with many stakeholders within the health market, and we know achieving affordability is a shared goal for all. However, healthcare prices and costs continue to rise. There is no silver bullet nor an easy solution to achieving more affordable healthcare. Our system is complex, but at its core is supporting critical care for those who need it, from prescription drugs to in- and outpatient hospital services. But state health officials are called upon to understand and address the high and rising healthcare prices and costs by their residents, employers, and taxpayers who are increasingly struggling to pay for them. Working with NASHP, state officials are seeking solutions for lowering the costs of health insurance and coverage to ensure as many people as possible have it. Groundbreaking but very high-cost prescription drugs compelled states to request NASHP's support to develop creative policy solutions to lower drug prices. Through those efforts, states dug deeper into their overall expenditures and realized their largest proportion of health dollars are spent on hospitals. State officials know how critical hospitals are to their community, from their staff of doctors and nurses to the life-saving care they provide. So officials sought assistance from NASHP to work together to better understand these costs and develop solutions to sustain access to hospitals while lowering the cost of healthcare. Hospitals vary dramatically. The term encompasses small critical access hospitals in rural areas, as well as urban-based university teaching hospital campuses with hundreds of beds and outpatient clinics, to a myriad of those in between. So when state officials asked NASHP to help them understand how much it costs hospitals to provide patient care, we went to hospital-completed Medicare cost reports. We analyze individual hospital data that is submitted to the federal government based upon Medicare cost report instructions, and we use national accounting calculations. Over many years, with feedback from state officials, support from Rice University and Mathematica, as well as input from hospitals and health systems, we are sharing the 4.0 version of that tool today. The tool is intended to provide state officials with information such as costs, charges, payer mix, and more for individual hospitals that most would not otherwise have. Very few states have staff capacity to collect and analyze this information. All states want data to make informed decisions about policy, and as noted, healthcare affordability is a key state priority. By supporting the development of this tool, NASHP isn't suggesting that hospitals are the only healthcare cost driver within the system. We also recognize that hospitals and health systems need to continue to thrive and provide services in their communities. We are simply supporting states in understanding more about the complicated financing of essential market participants that state officials are striving to sustain while addressing increasingly high healthcare costs for individuals. With that, I'm going to introduce my colleague, Marilyn Bartlett, a senior policy fellow at NASHP with roots in health insurance, with roots in health insurance and at the state level, who is going to walk through a live demonstration of our tool. And I will just note, we did not grab screenshots ahead of time. So there may be some corrections that have to be made as the tool is navigated. But we are so happy to be able to provide this live demonstration to you. Marilyn, I'm going to turn it to you.
Well, thank you, Maureen. Thank you very much. Yes, we're excited to show our new version. And I'm going to go ahead and start with a demo. Try to. Are you able to see my screen?
Yes, Marilyn, we can see the top of the page. It's perfect.
Great. This is what the new tool looks like. Now, it looks similar to the other tool, but across the top here we have tabs, and they're a little bit different than they were before because we received feedback from states. They wanted more information, or I should say you wanted more information about health systems and the different states they operated in. So we did change a few things that we'll go through. But we are now have Tableau as the platform. I think you're going to like it. We had Metabase before. With Tableau, it's a little bit easier to download items and graphs and charts. You also don't have to do as much scrolling, and it's faster. So we hope you'll use it. Now to the first tab, which is the overview. You can see that we have updated this as of February 7th. Now we have changed the downloadables. We used to just do a downloadable data set that was from 2011 through all the years. And we received the feedback that'd be nice if you could do a downloadable data set for just the current year, for maybe just the last 3 years, and then the full data set. Now, when you click on this, you can download the Excel version that contains the metrics that you'll see on our dashboard. As Maureen mentioned, the source is the Medicare cost reports. It represents approximately 70 million patients and $90 billion of hospital net income in 2023. Then down here, we talk a little bit about the different tabs that we have. And we talk about the key concepts if you're interested in how these measures come together. So I want to start off by doing just a demo, and we're going to explore a state. Now, I have pre-populated this with Indiana. We're doing some work with Indiana separately, and I thought it might be helpful if we could look at Indiana as a whole. In this particular chart at the top, I want to show you that you first select the choice, which I did, the tab, Explore a State. You check a domain, and I'm checking revenue and costs. You set the filter. I have pre-populated this with national and Indiana. And then you're able to choose from a myriad here of different metrics that you want to look at. So the first thing I'm doing is looking at revenue and adjusted patient discharges. And you can see that Indiana is running a little bit higher than the national level. Now, these are stated as far as medians. We take it down a step further and we look at it by bed size. So this is within the Indiana hospitals. You can see how you measure compared to national. And this is where we saw the increase higher than national, but you can see how it spread over the different hospital sizes. We can look by ownership. Now in Indiana, government is quite high. There's 23 hospitals. Indiana University Health is included in here, which is a very large facility. So that's going to make that larger. You can scroll over any one of these bars and you can see the hospital count number 23. You can also click on it to highlight it if you want, or just click out of it not to. And this can give you a little bit more information on the distribution of those discharges. We then, now that we've established discharges for the state, we're looking at net patient revenue. Now this is compared to national, and we saw revenue go up just like national did, and now we're seeing national a little bit higher. Now this is one component, this is revenue, but we've got to compare it to costs so that we can come up with the profit margin too. So we'll drill down again by bed size. You can take a look at, this is the net patient revenue per adjusted discharge. Again, you can hover. And by ownership. Now we move into the other side of the equation, which are costs. Now this is interesting because you'll see Indiana's cost is lower than national. There are 116 hospitals in this analysis. Now you can click on any year and get a little bit more detail. We look at the operating costs per bed size. We see this variance here that we just saw on that on the trend chart, and you can collect any particular year that you want. You could go back up here and you could say, well, I want to see what it was pre-COVID. And you can look at any specific year that you want to. It's much easier to look at specific years in this Tableau format. Again, you can look at ownership. You can compare, you could hover, and you can change years. The next thing I'm going to look at is profitability, which pulls these two things together, the revenue and the hospital operating costs. And here's where you can see some variance for Indiana. We saw revenue was about on track, but costs were lower. So you look at national here, and this is the operating profit or loss per adjusted discharge. And you can see with Indiana, you can see how many hospitals, you can see the median operating profit or loss per discharge. Again, just as we saw before, we're going to drill down by bed size. And this first one shows you that operating profit or loss per adjusted discharge. You can start seeing the variance here in these 16 hospitals compared to national. And you can see that they're all a little bit higher. We can check operating profit by ownership. This looks so small, it looked like national. You can see what the median is there. It's 980 hospitals for government, and the median is -15. We convert this to a margin. It's going to follow the same pattern as that profit loss, but it's going to be stated in operating profit margin. Again, we can go by bed size. You can look at these different ones. You can hover over and see how many hospitals are included, what the number is. You can change it by year, so you could look at any year you want. And we show it by ownership. We then go to net profit margin. Now, this is interesting. What you're going to see happened in 2022 were unrealized gains and losses in the stock market. That's going to be a net income, and we saw them both drop. You'll see that Indiana follows that national pattern, but is higher. You can see the medians again. And I'll skip through these pretty quickly because it's still that you could see the bed size and you could see the ownership. We then jump to the bottom line, and we like to show cost to charge ratio, which we'll get into a little bit more. And you can see that the cost to charge ratio for Indiana is running a little bit lower. And we'll look a little bit later, it's more that the charges have increased. You can compare it by bed size, and you can compare it by ownership. But let's look at commercial break even. This is interesting because it follows the same national pattern, but is going a little bit higher than the national pattern. Now, break even as defined is what the commercial population would need to pay as a multiple of Medicare to allow that hospital to break even, to cover all their costs, all their unrealized gains and losses on stock, all of the expenses, even those that are not hospital patient related directly. Again, we can switch it by bed size and by ownership. So that's pretty much by state. Now I'm going to jump over to the next one. This is where we're bringing in some different items. I'm going to look at Indiana to compare the health systems that are in Indiana. And at this point now, we've moved away from medians. States were more interested in total. So we have combined and recalculated the metrics based on a total. So when we compare health systems in Indiana, this lays out all of the particular health systems. Now we're limited in Tableau. If there are more than 20 systems, we are not able to show that particular system name attached to the bottom of the graph. So you won't see that, but you'll have to hover over, and you can see that definitely the largest is adjusted patient discharges is Indiana University Health. And you can get some of these smaller ones, and you're going to have to hover over that to see which it is. We then look at profitability. And again, one thing I want to tell you is that this tends to pop back to Alabama, and we're working through that. So just make sure that you always double check the filters when you're moving into the next chart. So, let me try profitability. Here I am in Indiana, operating profit. And this is total operating profit. Again, these are new charts. And you can see Indiana University is over $1 billion in operating net profit. You can move through these. I want to point out Eskenazi, we've done some work with Indiana, and we know that Eskenazi is a hospital that really serves a community much in need. And so you're going to see them throughout, maybe at the low end on some of these charts. Operating profit margin, again, you'll see that Eskenazi's running at -23. You'll see that these different systems here, Ascension, a big one with 15 hospitals, 28%. So you'll need to hover over. Now we get to net income loss. Now this is all expenses, even if they aren't hospital related, and all revenues. And you can scroll over the different ones. And again, this is looking at system. Net profit margin expressed as a percentage. And we look at the total charity and uninsured and bad debt. Now, this is interesting. This is where Eskenazi jumps to the top of the chart. As I mentioned, they serve basically an underserved population. And so you're going to see that 8% of 8% of their net patient revenue is applied to charity care cost, and 3% versus, when you get down here in the other end, you're going to see them combined about 1%. So let's skip over to the bottom line. This is going to be showing break even in RAND. As you know, the RAND survey is conducted every year, and it looks at a set of commercial population as well as where they're able to obtain all payer claims database data to determine what was paid as a price as a multiple of Medicare. For Indiana, you're able to see across the top here, and this chart's going to be pretty populated because there are these many systems in here. But you could look over here and you can see with Ascension, the median commercial price is 346% of Medicare. And you're going to see that the commercial break-even is 189. What I'd like to show you on this is to change years. If you want to go back to a prior RAND study and prior Medicare cost report data, you can pop back to 2018 and you'll see these change. So this may be something that you'll want to work with. Now we've added some new charts. We heard from states interest in hearing about drug costs and drug charges. The Medicare cost report does include inpatient charges, outpatient charges, and total drug costs for the hospital. So in this particular one, we're looking at the orange or what the drug costs are. The blue or what the drug charges are. Now, that is not the price. That is like the manufacturer's list price. So what the charge amount is, and then the hospital may have a price from a fee schedule, a discount off a charge master, or a price by a particular agreement. So we do want to show that spread, but states are very interested in that, so we thought we'd look at it. The other thing we thought states wanted to know was the move from inpatient and outpatient. As we have seen, there has been a move over time to more outpatient drug charges, whether it be from a hospital infusion site that is considered outpatient. Hospitals, some have opened their own specialty pharmacy where a large dollar amount is. So we started wondering about that shift. You'll see each one again, you'll hover, and I'll look at Beacon Health System, and you can see there's 2 hospitals there. Parkview, 7 hospitals, and you can see the switch. Now, this is interesting because you can go back over time, and let's take a look back at, I was on 2018. Let's jump to 2023. You're going to see more. You're going to see more outpatient. So there is that move. And then, I'm sorry, I had it on a different year, but let me go back to the drug costs and charges. Again, you can go back to any year and take a look at that. So the next thing we wanted to take a look at was to view a particular health system. So we've looked at states and we've looked at comparing health systems. Now let's view a single system. And I pre-populated this with Ascension Health. And the charts here will show you this. Now I'm looking at Indiana, and you can see that total adjusted discharges in Indiana, they have 15 hospitals are running around 184,000. The most in Michigan. You can see a presence in the particular different states. And then you can also see here by bed size. These are discharges. We jump to profitability. And this is operating profit in dollars and cents. And we're able to see of the 15 hospitals in Indiana, the profit margin. You're able to click on any of these again if you want to look at Michigan, if you want to highlight it to hang in there for a minute. You can look at Texas, 9 hospitals. Where is Texas again? 9 hospitals. And you can look at bed size. That's total. Now, what we've also done is included the map here. If this is easier to look at, you could scroll over each state and you can see where Ascension is in these different states. You can see the total operating profit and also the number of hospitals in each state. Same with the margin. We can look at the margin either in a bar graph, a trend line. We can compare it by state. We can compare it by bed size. We can also compare it by the map. And again, you could hover over the map and get more of the detail, depending on what you want. We then go down to net income. Now, remember, this includes everything. So this is the total of the health system. And you see they're dropping down here on their profit margin. And on net income, you can look at the particular states. You could look at bed size. Again, you can drop down to the map. And this will show you the same numbers that we had on that bar graph, but it shows you in a map, which might be what you want. And while we're here, I want to mention, I'm just learning Tableau, so many of you will know this much better than I do, but this is very nice compared to where we were before. If you want to download this, you can click here. You're able to download the image. You're able to download a PDF, or you're able to download a PowerPoint slide. And then a colleague here at NASHP has been playing with this and showed me how once you download it, then you can trim it, you can narrow the focus, but you could use it and put it in a particular document or a PowerPoint that you're using. This is going to be a real useful tool for us. I also like over here on the map that it can scroll between the lowest to the highest. Same view on net profit margin. And again, when you go to the map, you're able to see the low to the high, and you're able to see the color coding here. Charity care, uninsured, and bad debt. This was interesting to me because you'll see that as a system, you're seeing that the pink is the charity care cost as a percent of net patient revenue. It's running around 4%, and this is total. And uninsured running around 1%. And it's interesting to look by states. Texas is fairly high, 11 hospitals there. And then it's also interesting to look at bed size, and probably not a surprise, the critical access hospitals versus some of the larger ones. So that we bring in a lot of the same data, but the key point on systems is we're now showing total, not median. The bottom line, we look at break even and RAND. This is the median commercial break even for all of Ascension hospitals. And again, you can see it's 94 hospitals. The break even median is 139. We use the median from RAND for the same Ascension hospitals, and you can see that difference. We're looking at drug costs. Again, these are the new charts we've added at state requests. And you can take a look at the different states. Blue are charges. Orange is showing you the different costs. And as you scroll across here, you can see by state and you can see by bed size. So drug costs are one we're just starting to come across with. We do compare across hospitals, and I'll go through this fairly quickly because you're going to see it's some of the same charts. but then we're pulling it down to the hospital level. We've moved away from system now. We're looking at the hospitals for Indiana, and I could have chosen just a particular health system, bed size, or hospital ownership, but I'm going to just leave it at the high level. Now, again, because there are so many hospitals, we don't have this. Now, if we narrowed down and we said, okay, we want just, excuse me, I'm still learning this, so I apologize. It will narrow it down. Let's just look at this size. You can see now that we'll populate with the names. And when you hover over these particular bars, I'm not doing very well on this, I apologize. When you hover over the bar, you can get the information. You can look at net patient revenue per adjusted discharge, again, hospital operating per adjusted discharge. Now, since this is at the hospital level, this is their actual results. We can look at profitability. And here it popped back to Alabama, so I encourage you to always check that you are on the right state. These are the different hospitals here on operating profit margin, net profit margin. Now this is going to bring in all expenses, and you'll get a chance to see. Again, I've chosen this bed size range, and so I've narrowed that look. Net charity care cost. Again, be sure to look at this screen here. And this is arranged in ascending order. You'll see that on the break-even chart where we do have the names that I showed you before by the state, we did those in alphabetical order because it's easier to find. This is going to be in ascending order. Same with uninsured and bad debt. And what we do there is we take from the Medicare cost report what the actual cost was. So this is not charge master. This is the actual cost of those services. Bottom line, this is cost to charge ratio. And as I mentioned, we can see the difference. This one, again, I've got this narrowed by hospital size, but you can see these different ratios. And we'll go into specific hospitals because that tears it apart or drills down on it. How much of it is a change in costs over time? How much is it in a change in charge master? And again, if you want to, you can go back to different years. You can examine those trends. We look at break-even ratios. We line 100. This is what commercial would pay as a multiple of Medicare for that hospital to be able to break even on all of its costs that it reports, even those not related to hospital care. Hancock, it comes in at the high one in this range of groups. Again, you'll have to hover over them. The next step we do is compare it to RAND. And here you'll see the commercial break even compared to the RAND price for this subset of hospitals. You can change this, and let's look at the 251 and over. And this is going to give you these particular items. Now, this is interesting because Eskenazi comes in a little bit lower here. And the reason is Eskenazi receives government appropriations that aren't included in net patient revenue, but come in later. So it's a government hospital, and government hospitals can be kind of tricky, and you have to drill into a lot of other data on them. Now, this particular hospital, Ascension in Evansville, it's the one we're going to drill down and look a little bit more at. We heard from states that the need for labor costs now had changed. During COVID and right after COVID, we had a lot more labor charts because states were focused on that. So we focused more on direct patient care labor as a percent of the total hospital expenses. And we can see these particular hospitals. Now, it's interesting on this one, you'd want to go back and look at different years. We look at the labor costs, direct patient care labor per adjusted patient discharge. Again, we go back to COVID times, and you're going to see that these numbers are different. So you can bounce between years and see that. And this is direct patient care FTEs. How many people? And this direct patient care is salaried and hospital staff, as well as contracted staff. So you can see the direct patient care FTE per 1,000 adjusted patient discharges. So really the number of people per discharge. I'm going to skip out of this and go to the last one that we're going to look, because I think that states are using this one. States have asked us to provide more on system totals because states need that information. But we've also been working with some states directly on viewing a single hospital. So I pre-populated this with Ascension in Evansville, Indiana, since our focus to track from top down was Indiana. And you can see here the different domains, and we're going to do a quick view at all of them. Again, I selected Indiana and I selected Ascension in Evansville. And the different metrics, so first we'll look at adjusted patient discharges. They've seen discharges go up. That would mean probably more volume coming in because adjusted patient discharges is calculated to estimate the inpatient, outpatient together. Excuse me. Now we take a look at net revenue per adjusted discharge and hospital operating costs. One other thing I want to note, if it gets kind of confusing what this is, you can just hover over the title of the metric here, and it will tell you what a question that this may be answering for you. You can look at net patient revenue per adjusted discharge. You can look at each one of these metrics, and it will give you the definition of how it's calculated and the definition. So we can see over time that this is the range. Now, it's interesting, in 2023, there was error in the reporting. If you see it blank, it pretty much means an error in reporting. In previous models, we have in the benchmarking for states, we have removed some of the outliers. And in this particular case, this year, version 4, we're bringing in the whole range. But if it's not reported in the Medicare cost report and the calculation can't be completed, then it's not there. But you're going to see this range will be operating profit. We look at the particular categories, and this is interesting because you're going to see for this hospital in 2023, 24% of their costs are direct patient care labor. And, excuse me, I'm on Alabama again. How did I do that? I really apologize to you. All of you out there that are Tableau users will be able to just kind of smile and say, you can tell she's a newbie on this. But I'm going to bounce back to Evansville. This is the chart. Yeah, I knew that once I saw that chart, I knew it wasn't quite right. But this is interesting. When you add, it's 17% direct patient care labor and 15% other. Now, this isn't surprising for a system hospital because maybe a lot of the accounting and whatever is, also coming from home office. But I think the thing that's interesting here is if you add these two together, the 15 and the 17, you're coming up with 32% of this hospital's costs are labor. And that's an interesting discussion point because we're hearing in the media and some hospitals, their labor costs are 60%, 70%, but not so here. But this bar, which is other hospital operating costs, which can be supplies, drugs, contracting. And I think that this would be a good discussion point for us to drill in further, or a hospital to drill in further of what's here. We can look at it as percentages of the total, or we can look over time. And as that other chart showed you, that the blue is other hospital operating costs. Why has this gone up? Now we hear of inflation, we hear of increased supply costs, but we'd want to look at this a little bit deeper, I think. And you can see that direct patient care labor costs did go up through the pandemic. They spiked here and they've come down. Capital related is going to be depreciation, interest, lease expense, and then this particular, I just discussed that. Yeah, this is going to be additional operating expenses not related to hospital patient care. And that's going to be other expenses that they include, such as investments, equity ownership in subsidiaries, partnerships, etc. We can click on profitability. And we can look at their operating profit per adjusted discharge. Operating profit margin, again, that same kind of trend, unless you were to see a real different amount in revenue. Net profit margin. And we can come down for this specific hospital. I wanted to particularly show this chart because it's important on this graph to hover over to get the percentage. We have rounded it, but you can see right here when I looked up the detail, both the charity care and then the uninsured and bad debt were both at 1% of net patient revenue. Let's bounce over to payer mix metrics. It's really important to understand the payer mix of the hospital. So looking at this particular one, we break it into 5 payer groups. You'll see that this is charity care and uninsured and bad debt. Now, this payer mix is not based on revenue, it's based on services. So it gives you a better idea of the volume. Is 2% of this hospital is focused on charity care, uninsured, and bad debt. The bulk is commercial at 40%. Now, what we've been seeing is gradually we've been seeing this increase in Medicare Advantage corresponding with a decrease in Medicare. And this is what you read about constantly, is that more people are moving to Advantage and leaving Medicare. This is interesting to me, this drop in Medicare, though, and wondering how much it might coincide with this increase in commercial. And it could be their reporting, I'm not sure. Medicaid is coming in at 16% of their payer mix. So then we look at the operating profit and loss by each one of those. And this is the operating profit margin by payer. Now, commercial is running right at about 58%. You're going to see Medicare and Medicare Advantage switch. We were able to adjust our Medicare Advantage calculation this year. Prior, we had it related more to Medicare, but CMS produced the rate variances back to 2011 in their MedPAC report that was published in March of 2024. And we were able to also alter some of the indirect medical education payments that are specific for Med Advantage. So we were able to do some recalculations there. And then you see they have a 52% loss on Medicare and government programs. Now you have to weight the operating profit and loss with the volume of services. So we bring those two metrics together that we just saw. So you may be losing 54%, but what percent is it of your population? So here we see that the government lines are all falling below 0%. Now, when weighted, you can see what the impact is. For Medicare Advantage, it's a -3%, -5% for Medicaid. And then for your state programs, you're seeing a -8%. And commercial weighted comes down to 23. The
Marilyn,
bottom, yes.
this is Maureen. I'm so sorry to interrupt. Before we leave this page, I just wanted to flag, we did get a question. We have others and we will address those at the end, but this one is very particular to payer mix, Medicare and Medicare Advantage. I know you just shared the update that we used from MedPAC to better differentiate between Medicare and Medicare Advantage, but would you mind just stating that again? I think there's some questions about how RAND treats the information, and I just want to reiterate how NASHP treats that information and the changes that we just made.
Certainly. On Medicare Advantage, the change we made was we went back and we looked at the MedPAC report, and the MedPAC report by year gave a different relationship to the fee-for-service rates. And so we applied that. We also worked with CMS directly to make sure that the revenue sources we were reporting were right. Were they Medicare, were they Medicaid or Medicare Advantage? And we found a revenue source that was Medicare Advantage that we had been reporting as Medicare. So we moved that source over. For the payer mix, we use a calculation based on their reported Medicare HMO, well, it's really managed care versus regular straight fee for service. So we're using that relationship to come up with the payer mix, the volume. Does that answer the question?
I think so. And just also to underscore, our source of data for this is different than the one RAND uses. We're
Yes,
getting directly from the Medicare cost reports and then adding these layers of new information to get it as accurate as we possibly can. Is that statement correct?
perfect. That's exactly right.
Okay.
Our source of data are the hospital Medicare report, or Medicare cost reports that have come with their own instructions. And they we follow just that source. Now, RAND does a survey of employers, self-funded plans, all payer claims databases, insurance companies, and they gather claims data. So we use completely different data sources on that.
Thank you.
Thank you. And I'm going to jump now to the your timing's perfect. Look, this is for this particular hospital because we're going to be talking about break even and RAND. And what we wanted to demonstrate is these are the hospital operating costs. And you can see the trend over time. And then you can see charges. Again, charges are not the price. Charges are the charge master rate, and price may be in between here. Now, when I was the administrator of the Montana State Employee Health Plan, I didn't want to pay a secret discount off of a charge master rate. That would be controlled by whatever the charge master rate went up or what the insurance carrier negotiated. So that's why I chose cost plus. I wanted to choose something as a multiple of Medicare so that it would be more transparent and really more controllable. Now you'll see this is a trending down cost to charge ratio. But the reason it's trending down is more that charges have gone up. This particular hospital, we are comparing it to RAND. Now, we're using the commercial break even that's calculated from the hospital Medicare cost report. And again, this break even considers all costs of the hospital, everything that they reported. And you're going to see the RAND price from their particular survey. You can look at the different RAND studies, and we you can see on the drop down, this is RAND 3.0 price. We moved to RAND 4.0, and then we brought in RAND 5.1 that was released. So you can see which RAND study was there. Labor costs, we go into a little bit more detail here. States wanted to know a little bit more detail by hospital. So these are the hospital operating labor costs. And you're going to see these are the total costs for that hospital. And this top one is direct patient care. And we saw things escalating during COVID. Maybe they spiked and they're starting to come down. This is total costs. So this hospital had 103 million in total costs. Home office and affiliates, they have 49,000. And sometimes you're going to see this on a system hospital. They may have lower admin and management costs because maybe the accounting, procurement, those types of things are done at the home office level. The blue is management and administrative costs. Again, on a system hospital, you'll probably want to be looking at both these. And then you can look at this, which is overhead. That will be housekeeping, dietary, and that's been fairly flat. Now, this is interesting. Here we're looking at the FTEs that are direct patient care, the FTEs that are management and labor, and we're dividing that total salary and benefit cost by the number of FTEs to see what's the average person in those roles kind of making. And so you see from home office, this is the particular it for 2023 is 144,000, and you can drill over time. You can see management and labor has gone up. And again, this is going to be driven by markets. Everybody's labor market is a bit different, plus the hospital's needs. Direct patient care labor, this is going to be contracted and salaried by the hospital. And you can see what those rates have done over time. And this is interesting. We consistently see that they were fairly flat. And then after COVID hit, the rates went up, and now they're starting to come down a bit, but each hospital's a bit different there. Overhead has range, but again, fairly flat. Now, this will show you just direct patient care. And this is hospital salary, benefits, and salary. And then for contracted, it's their contracted rate. And we heard from states and from hospitals that labor costs definitely went up during COVID, and we are starting to see them come down. And we are starting to see less reliance on contracted labor in some markets and for some hospitals, but not all. You have to look at the specific hospital. This is the direct patient care FTE count. So for this particular hospital, these are the contracted FTEs, 16. Now they've been dropping for salaried, they're at 955. And every labor market, every hospital has their own metrics that they will go by. We look at the hourly rates, and you can hover over to see what those are, but I sure want to leave a few minutes in case there's some discussion, Maureen. So the last is the drug costs and charges. And right here you see these are lined out by hospital over the year, the charges. Hover over it, you can see the charges are 374 million and the costs 99. And again, finally, the bar chart, which will show you what I had discussed a little bit more, the move to outpatient from the inpatient. I think I've talked enough, Maureen. Should I close out of this? And
Thank you so much. And we do have a couple of questions, and they're sort of foundational. So I just want to pose a couple of them. I know we're going to run out of time, but Why Medicare cost reports, Marilyn? I know we've talked about this from NASHP's perspective a bit, but I do think it's useful for the context of presenting all this data. So in answering that, why do we use Medicare cost reports? And the follow-up is, some people have referenced that there has been pushback that they are not the best data source to use to understand hospitals. What is our response to that?
Great. Thank you, Maureen. The Medicare cost reports are the only public source of hospital costs. Now you can use an audited financial statement, but that's going to be at the system level, and it's going to include a multitude of other entities. We just did an organizational chart for a health system with over 1,000 entities. And so it's going to include all of that. You can't just boil down to one hospital. So the Medicare cost report is the only public source for hospital specific. Even if you use a 990, those can be filled out by group, a group return that can include several facilities, and it can include disregarded entities, for-profit entities. It's difficult. So we chose the Medicare cost report because it is the only public source that you can get to hospital costs. We knew that the income statement that's published within Medicare does not follow generally accepted accounting principles. So that's where we move costs and we move revenues so that we can follow general GAAP format to make that change. So that's why we used Medicare cost reports. The pushback that we've received has been on operating margin, that the operating margin in the Medicare cost report is very, very low compared to ours. And the reason is that the Medicare cost report calculates the operating margin on just net patient services revenue, then all expenses. But some of those expenses are covered by other revenue that's not included, such as research, pharmacy sales, 340B income, a lot of those. So we move expenses out that are matched by other revenues or expenses that aren't related to the actual hospital providing services to patients.
I am aware of the time. I am going to I thank you, Marilyn. I think that was extremely
Great.
helpful. I think the demonstration was extremely helpful. If we didn't get to your questions, we may already have answers for them on NASHP's website. I do want to point folks to the fact that we do have downloadable data sets from all the years 2011 through 2023. We even broke them up because some people have told us, like, I only need the most recent, that kind of thing. So there's a couple options for downloading that information. There's also a resource that gives variable definitions. We also, on our site, have a hospital cost tool calculator that is an Excel format that literally walks the user through the different places within the Medicare cost reports that we pull to do the calculations so that a user could replicate the information that's in the tool by walking through that Excel sheet and using a Medicare cost report. And we do have materials on the relationship between break even and RAND. I know there are questions about that. With that, I'm going to close us out, but thank everybody for sticking with us through this hour. We know this can be really dense and really complicated. We encourage you to try it out and look forward to future conversations about the tool. Thank you, everyone.